summary. I'm Justin Badal. I'm one of the assistant professors at Baylor in the Department of Urology. So this is a little bit of a different talk than kind of going along those same lines of not a lot of urology in here, probably more anesthesia than anything with the studies I'm presenting. But it's kind of our brain at the therapist's office. So I just want to look at defining what is cognitive bias, and then how do we see cognitive biases in practice, training, and what is its impact on patient care? And then what are some ways to challenge our biases as we approach it to practice and training, et cetera. So cognitive bias, so a lot of it is defined as decisions based on beliefs. So it was first defined by Tversky and Kahneman in 1976 when they published kind of their, I guess I would say, landmark paper, because they defined this in a very thorough fashion. So essentially, decisions that we make are inherently based on beliefs of a likelihood of uncertain events occurring. So they model this based on heuristics, which are mental shortcuts that allow people to solve problems and make judgments quickly and efficiently. So I want to analyze 3 different heuristics that they mentioned in their paper, and there's many of these heuristics, but these I think are the ones that are all kind of readily accessible in our own minds. So representativeness, availability, adjustments, and anchoring as their own. So here's just a quick question. Steve is very shy and withdrawn, invariably helpful, but with little interest in people or in the world of reality. A meek and tidy soul, he has a need for order and structure and a passion for detail. So just in the interest of time, I had it prepared a poll everywhere, but the question here is, what is Steve's occupation? So don't join, I'm not gonna activate it just so we can keep moving along. But I want you to get, what comes to mind? What is your first answer? What would you think of based on that description? Shy person, he's kind of disconnected from reality, he's helpful, but he doesn't like interacting too much with people. So this would be then, we take that information. Librarian, okay, librarian times 2. So anyone else? So librarian. All right, so we all have our biases and we're all showing them, so that's good. Good. So representative is a heuristic that applies probabilities to the degree which something represents or shares similarities to something else. But it ignores a lot of different factors that it should affect our judgment. So prior probability of outcome. So it ignores the fact that more farmers exist than librarians in this world. So the likelihood of Steve being a librarian is probably lower than him being a likelihood of being a farmer. But it doesn't affect the similarity of Steve to a farmer or a librarian, so our brain can kind of still latch onto that. So insensitivity to sample size. And again, although this kind of ties into the previous one, but it's a failure to consider the sample size of a population when making a judgment. So for example, people will assign the same average height of men regardless of the sample size being 1,000, 100, or 10. We just understand it as there's a sample size. What is the average height of a man? We don't really pay attention to that. And then there's the misconception of chance. So people expect that a sequence of events generated by a random process will represent the essential characteristics of that process, even when the process is short. So for example here, with the above flipping of a coin, the second order seems like it would be likely to occur. Heads, 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 why not tails, tails, tails to follow? But in fact, in reality, we know that each individual flip has its own probability of happening, which is independent of the others. But our brain would like to tie it into a pattern that we recognize. And then you have insensitivity to predictability, and I'll kind of move a little quickly here, and then the illusion of validity and misconceptions of regression. And I want to just touch on misconceptions of regression. I'll expound upon it a little bit more, but this has something that's impactful to many people who are like ourselves, who are surgeons, working with either new people, working with trainees, finding ourselves in situations where we have to either push someone's boundaries or kind of reduce their boundaries or their limits, et cetera. So just another question. So fighter pilots who had a smooth landing and were praised had a subsequent poor landing. Pilots with a poor landing were punished and subsequently had a smooth landing. If praise or admonishment were withheld, how did the performance change? Oh, sorry about that. Sorry about that. There we go. So fighter pilots who had a smooth landing and were praised had a subsequent poor landing. Pilots with a poor landing were punished and subsequently had a smooth landing. If praise or admonishment were withheld, how did performance change? So poor pilots kept performing poorly, and smooth pilots continued to be smooth, or performance was unchanged. Smooth followed by poor followed by smooth. We'll move on to the next one. We'll move on, but just think in your mind, where do you think this went? So this has to do with the misconceptions of regression. So regardless of reward or punishment, repeated examination will demonstrate an improvement after a poor performance and a deterioration after an outstanding performance. So this has to do with the fact that everyone has their set. They have their point at which they perform. And either you can find that point in somebody, or you can nurture that point and kind of take it and kind of expose it and see where it is. But this is the idea of the regression to the mean. So if we ignore this, then we have this erroneous conclusion that punishment is more effective than reward, which is what we tend to see as human beings. When we punish somebody, the performance typically will improve later afterwards. However, in fact, it has to do more with this regression to the mean. And so it implicates us as being just bad people, because we really can't understand that it's not about punishing poor performance, but it's in fact identifying someone's ability and trying to raise that ability either through teaching or nurturing a skill set, or trying to overall assist with that. Because if you can bring up their set point, their regression to the mean will be higher than it was previously. So in my mind, neither reward nor punishment are necessary in this case. That being said, you can still tell someone they did a good job, or you can still critique someone for their work if that's part of raising their set point of their performance. So in my mind, this also applies to the concept of servant leadership and management styles, and that has to do mainly with a leader that acts as a servant leader is one that is trying to buoy the entire organization, or trying to buoy those that are below him. It's not a leader pulling a boat full of people, but instead he's in the boat with the people rowing as well, trying to make sure that everyone is advancing to their set point so that regression can overall improve. I think this is an important one that we as surgeons need to take with us as we kind of go forward in our daily lives. And then the availability heuristic. So this is a judgmental heuristic for assessing frequency or probability. People assess the frequency or probability of an event by the ease with which instances can be recalled. So let me just, to keep this brief. So for instance, biases of imaginability. So the risk involved in a surgery is evaluated by imagining contingencies with which the surgeon is not equipped to cope. So the surgery can be made to appear or to be exceedingly dangerous despite the ease with which disasters are imagined. This does not actually reflect the actual likelihood of disasters happening during a case. But the converse can also be true if the dangers are either difficult to conceive or don't come to mind. And so it's easy in our minds to bring forward this information if it's there, and we can bias ourselves into a discussion one way or the other. And then just illusory correlation. For instance, if a patient has a TURP on a Friday TURP on a Thursday, and the catheter they were late to clinic, catheter came out at 3 p.m., and then they go into clot retention, and they end up in the ER at 2 a.m., and then you're there working on their bladder. That will then form a bias in you saying, I will never ever remove a catheter on a Friday night or a Friday afternoon appointment. So these are things that can recall in our mind as we develop these biases. And then adjustment and anchoring. These are different starting points yield different estimates which are biased towards the initial values. So the initial value or starting point may be suggested by the formulation of the problem, or it may be the result of a partial computation. So for instance, for example, so estimating the percentage of something can be influenced by being provided a number. If you spin a wheel and then are asked if the actual number is higher or lower, you will anchor to the already presented number. So if you see the numbers that are there, you'll kind of already base it on what you know there. And then we have these things called conjunctive and disjunctive events, which our mind tends to anchor on either what probability makes sense or how data is presented to us. And in my mind, these are things that take a little bit of explanation, and just in the interest of time, I'll keep moving. However, the idea behind these are you should wait for the entire analysis of a situation or an event before trying to make your assessment of something. You can't just anchor it based on the first piece of information. You have to gather every piece of information that you can get in order to make an appropriate decision. And so there's been kind of an explosion then in our understanding of biases, and I just analyzed 3 of them, and this is a mind map of all different sorts of these heuristics that can be used to bias the way that we think, bias the way that we approach situations. And so I think it's an interesting area to kind of concern ourselves with, because it's a lot of things that we're not typically we don't typically spend the time thinking about. We are just kind of firing off what comes in our mind at first. And so just to keep moving forward here, so let me just review some articles here, kind of how biases have affected clinical practice. And so this is looking at the downside of shared decision making. And so I highlighted 2 here. The first is attribute framing. So it says here, patients are expected to be more likely to choose a treatment when it is framed positively. So for instance, an 80% chance of survival versus a 20% chance of mortality. So depending on how we frame things, how we present things to patients can be very important. And then absolute versus negative risk presentation. So men that have an undescended testicle have a statistically higher chance of having testis cancer than compared to the general population. But in absolute terms, it's not a very high, really high change in the risk, or not a greater increase. And so we need to explain that when we're talking to patients, that yes, if someone who has a father with prostate cancer, yes, they have a 4 times risk of having, their son has a 4 times risk of having prostate cancer. But again, that's a relative risk, not an absolute risk. So I try to tease that out with patients just so they don't kind of lock onto that one little thing and then have that make their decision for them. So training induces cognitive biases. So this was an interesting study published by our anesthesia colleagues in a simulated cannot ventilate, cannot intubate scenario. So the hypothesis was that initial training in only one technique would result in a bias for that technique, and that completion of training in a different technique would correct this bias regardless of the training sequence. And so what they did here was look at having trainees do a baseline evaluation, then a difficult airway lecture, and then they would receive either training in supraglottic airways or they'd go straight to a cricothyroidotomy. And then they had another evaluation, and then they retrained in the opposite training session. And so what they found was, in this case, in table 2, we have the supraglottic airway group increased the number of supraglottic airway use from base to mid-evaluation sessions, so they did improve on the number of supraglottic airways that they used. The supraglottic airway group, after crike training, increased the number of crike airways, but they maintained the number of supraglottic airways. And so the thought with the crike group, they increased the number of crike airways from base to mid, and they increased even after getting the supraglottic airway training. So being trained in the supraglottic airway did not actually change the crike group's mind. They thought that I have to proceed directly to the ultimate, which in this case is the cricothyroidotomy, and so they skipped much of the supraglottic airway maneuvers. So the order of training in this case did matter. Okay, and then I just also wanted to point out, so that was there where the numbers increase. And then in table 3, after completion of training in both techniques, there were no differences in the initiation of cricothyroidotomy. Now the main thing is, none of the, what I took away here was interesting was that none of the residents from the cric subgroup attempted supraglottic airway. So I thought it was interesting to see that, again, it kind of lays itself out that the order in which we train, can I go back one slide, sorry? The order in which we train, we present our training is important. Okay, and then this next slide, so this just shows that, again, the cric group, the interval time from going from a supraglottic airway to a cric airway was a lot shorter than those who had first received the supraglottic airway training. So again, the order of training matters. And then this is another study looking at how we present information. And this was a flowchart made by the American Society of Anesthesiologists that has to deal with, again, that cannot intubate, cannot ventilate, or cannot oxygenate scenario. And so it's pretty complicated. And so they wanted to see if you can do something that's more simple, how does that approach benefit or change someone's plan of action? And so they created this vortex model, which encourages everyone to use one of the 3 adjuncts and then just proceed to a cricothyroidotomy if those fail. So we have here now, this was the rating scale that they were rated on, and then we find in this table that more students in the vortex group used all 4 basic airway techniques and achieved completeness in terms of the rating than in the ASA flow sheet model. And so the performance of each is shown in the graphs here. And then I thought this was interesting. So the NASA TLX and the STAY domains, those look at mental exertion and stress. And they found that the ASA flowchart was actually associated with higher levels of stress and mental exertion. And again, it just has to do with how we presented the information, and then what does it do in terms of biasing how we kind of approach the information presented to us. And then one final one, just because it has to do with general surgery interns and assessing their skills, and I think it applies to some of those that are trainees in the room. I'll try to get through this a little quickly, but essentially, so the majority of these were categorical residents, with about 1/3 of them being women, and then participants' actual performance scores and self-assessment estimations were positively correlated. So someone that had a good self-assessment, they actually had good performance. However, on average, self-estimates were lower than actual performance, meaning there was kind of a trend towards people thinking that they were better than they actually were. Now, why does that apply to cognitive biases? So let me move over to the next table here. And then, okay. In table 2, they talked about that residents with a higher performance scores were less accurate in self-estimating their technical skills than residents who performed lower than the cohort median, meaning those that had a better job of estimating their performance usually estimated themselves lower than what their actual performance was. And when they gave their estimations, they were actually lower than the overall median. So there were people in the training groups that estimated the performance to be better than what it actually was, and they ultimately did worse than they actually thought they were. Now, however, what I find most interesting is those that were more honest with themselves about their assessment, they actually had the most improvement after 1 year. And so I think this ties into a trainee being more honest with themselves and understanding what exactly their weaknesses are and their strengths are, and then highlighting those during that 1 year of time, and then bringing it to bear and working on that. Whereas someone who's less honest with their weaknesses and their strengths, they're less likely to actually show improvement over that 1 year course. And so we should be encouraging people to be honest with themselves, and we, as those training them, should also be honest with our own skills as well, just so that they don't get this idea that, oh, we can do anything that's presented to us. And then just challenging some cognitive biases. So thoughts create feelings, feelings create behavior, and then that behavior reinforces our thoughts, and then you so on and so forth, you're circling around. And then I had this little picture here that we've all been in this situation when we're sitting in our car, cop turns on his lights behind us, our heart rates go to 120 BPM, and all we're thinking is, crap, we're going to be pulled over, and then the car zooms by, or the cop zooms by you, everything's relaxed. So how do we keep ourselves from doing that in everyday life? How do we keep ourselves from having that higher tick when we get that pressure applied to us? That's a challenge that I would like to pose to everybody. So, but thank you. I hope this was something different, and hopefully someone took something away. So we'll move on to the next one.